everyone. Today my topic for case presentation is therapeutic keratoplasty in young male with fungal keratitis. First of all, what is fungal keratitis? It is a life-threatening corneal infection that can progress rapidly if not managed effectively. In our case, it is highlighting on 19-year-old male with non-healing corneal ulcer despite intensive medical therapy. Given the risk of progression and limbal involvement, therapeutic keratoplasty has performed to control the infection and restore the corneal integrity. Our case is a 19-year-old male, student of Kanpur, came with the chief complaint of diminution of vision, pain and redness. The diminution of vision was gradual in onset and progressive. The pain was sudden and pricking in nature and gradually progressive. And redness was sudden and increased in few days and remained static, and with also associated with watering and whitish appearance in the black area of the eye, which is gradually increased in size since 3 weeks. Patient ignores his symptoms in the first few weeks, and after with the local practitioner, he was taking natamycin, then moxifloxacin, atropine, and timolol and voriconazole 1%. And patient also gave a history of vegetative stick matter trauma history of 3 weeks back in the right eye. On examination, his visual acuity was finger count, and on slit time examination, we had a 7 into 6 mm whitish grayish stromal infiltrate with feathery appearance and rough without any slog, and the epithelial defect was 5.5 into 5.5 mm with no endo exudates, no satellite lesion. And the corneal stroma edema was present with surrounding the infiltrate, and the hypopyon was approximately 3.5 mm in height. On KH, when we did the scraping, we sent the sample for KH, we had the septate hyphae seen, and the blood agar was also showing a fungal growth suspecting of aspergillus. We planned according to the age. Was the patient was young and there was limbal involvement. The patient was already taking medical regime for 3 weeks. We also have a good corneal tissue available. We planned for therapeutic penetrating keratoplasty was done with voriconazole wash, and the donor size was 9 to 5 mm, and the recipient graft was 8.5 mm. After the visual acuity was done on day 7, which was about to be 6 by 36, with we have the pupil mid dilated, and the iris pattern was normal, and the graft host junction was also normal. Within 1 month, the vision was 6 by 12. The unique about my case was the patient was 19 years, which is unusual for severe fungal keratitis requiring for therapeutic penetrating keratoplasty. And the unlikely many cases with fungal keratitis leads to multiple surgery, and the patient underwent early TPK within 3 months leads to good vision recovery. And clinical implication that if we have a large ulcer and limbal involvement, we have to go for TPK.
Thank you, Purva. So, any comment from the judges? Fine. Next will be Sakshi. So, one point, fungal keratitis, there is always a debate whether to go for early TPK or late. But this was a case of infection following
immunosuppression.
Trauma.
Yes.
Okay. Okay, but when she is right, if it is severe to begin with, and if it is not responding, then at times few surgeons they take a early call.